Okay, good evening, surgeons. This is Dr. Maheshwan Naidu, live streaming from Richards Bay. Today, we had planned to do some online mock vivas, but don't seem to have anyone available. Everyone seems to be getting quite busy close to the exam, covering extra shifts and so on. So I've decided to cancel the mock online viva for tonight, but instead I'm going to present a brief lecture on Barrets Oesophagus with some very useful endoscopic video clips which will help you to understand Barrett's more easily. Just going on to a definition. Barrett's basically refers to the replacement of a portion, typically we're looking at 1 centimeter or more, of squamous epithelium of the distal esophagus with a specialized intestinal epithelium, and this process is called intestinal metaplasia. It's important to understand that it's not replaced with the gastric mucosa, but with intestinal epithelium. The US definition requires a biopsy to confirm goblet cells on histology, and the UK or European definition, and macroscopic appearance alone is adequate. So this is an endoscopic picture showing the top of the gastric folds. The lumen of the esophagus entering into the stomach is in this area, and this area of tissue here above the gastric fold is abnormal, and when a biopsy is taken you see the goblet cells which confirm the intestinal metaplasia. The three essential steps for endoscopic diagnosis and description is to identify the squamocolumnar junction, identify the gastroesophageal junction, and then to describe the extent of the columnar mucosa, and we will be coming to the recommended method for doing that shortly. Now, it's very important to be able to identify the top of the gastric mucosal folds, which is the landmark of the gastroesophageal junction. And this slide is just here to show you how to identify the folds. So where you see the folds sort of blending with the mucosa higher up, that you would identify as the top of the fold, and that would be the endoscopic landmark for the gastroesophageal junction. Now, the extent of Barrett's is currently described using the Prague classification, and it uses two letters, C and M. C stands for circumferential extent, and M for maximum extent. So you first have to identify the OG junction, and then you measure from the upper limit of the gastric folds. You measure a circumferential extent, which in this instance is 6 centimeters, and then where there are little tongues of intestinal metaplasia visible, you measure the upper limit of that extent, and that will give you the M value. So now remember that this is all done in reverse, because the measurement actually appears at the patient's incisor level, because the scope is marked from the tip of the scope going up to the handle of the scope. So you would have to reverse all of this. For example, the OG junction may be at 40 centimeters. And as you pull it up, you find that the circumferential extent is 35 centimeters. So you would get your C value by subtracting 35 from 40, which gives you 5 centimeters. You would then look for the maximum extent, and you take that, let's say that was the OG junction is at 40 centimeters and the maximum extent is at 30 centimeters. So you then take 40 minus 30, which will give you the maximum extent of 10 centimeters. Okay, so that's how you use the Prague classification to describe the extent of the Barrett's esophagus. Then what about confirmation? The old method was microscopic biopsy, whereby we'd use the Seattle protocol and take biopsies at 2 centimeter intervals and take 4 quadrant biopsies. And this can be quite tiresome and requires a lot of extensive histopathological involvement. The new method is to use narrowband imaging. Right? This is a method of virtual chromoendoscopy. The different brands of endoscope have different names for it. Olympus calls it narrowband imaging. Pentax calls it iScan. And basically, this has been now accepted as a macroscopic confirmation of Barrett's. And what one looks for is the morphological characteristics, looking at the dysplastic areas and identifying blood vessel patterns and mucosal patterns. And if these are irregular, they can then be described as confirmation of Barrett's. This is an endoscopic image using NBI, which is on Olympus, and this shows non-dysplastic Barrett's epithelium. There are circularly arranged mucosal patterns indicated by the yellow arrow, with vessels coursing regularly along the mucosal architecture, and that's the red arrow. Another example on the right of the screen, non-dysplastic Barrett's, villus gyrate mucosal pattern with vessels arranged regularly along the mucosal cells, along the mucosal coil, and that is identified by the red arrow. Then we move to dysplastic Barrett's, which can also be identified on NBI or virtual chromoendoscopy. Here you'll notice the red arrows indicate irregular, longitudinally arranged epithelium with branched vascular architecture, and this does not follow the course of the mucosa. On the right, you see dysplastic Barrett's once again, elongated, high branched vessels that do not follow the epithelial architecture as indicated by the red arrows. Now, how would you manage Barrett's according to the following risk stratification? You've got high-grade dysplasia, that's HGD, low-grade dysplasia, which is LGD, and non-dysplastic Barrett's esophagus, which is NDBE. So this may be diagnosed endoscopically, and this would be, you'd use 4-quadrant technique, 2 centimeter biopsy, and this would be surveilled every 2 years, repeated after the first year, and then every 2 years, and thereafter every 3 to 5 years. Low-grade dysplasia and high-grade dysplasia. Well, low-grade dysplasia, firstly, probably better to ablate than to surveil. And in high-grade dysplasia, surveillance is no longer recommended. It must be ablated. And so it is only non-dysplastic Barrett's esophagus which can be surveilled. Just of note that there are better surveillance compliance with the non-invasive brush. This is called the CDX brush. However, a biopsy is still required, so basically you have to do both. However, the compliance amongst patients tends to be better when you offer them the brush initially, and then you would then have to convince them to come for to allow you to biopsy as well. The following consensus was reached at a consensus meeting in 2006 or 2005, and there was 80% agreement with the following. 1, the endoscopist should obtain multiple systemic biopsies from the suspected segment. 2, the patient should be enrolled in surveillance endoscopy. And 3, an adequate dose of proton pump inhibitors to control reflux symptoms and erosive esophagitis should be maintained. What is the natural history of high-grade dysplasia? Most studies suggest 6 to 10% progression to cancer within a year. And who should be referred for endoscopic eradication therapy, EET? So basically, all patients with high-grade dysplasia must have endoscopic eradication therapy. What about low-grade dysplasia? The majority of low-grade dysplasia, when assessed by a second pathologist, are found to have inflammatory non-dysplastic Barrett's. Therefore, low-grade dysplasia can only be diagnosed once confirmed by a second pathologist, and at least one of the pathologists should be an expert GI pathologist. More recently, data regarding low-grade dysplasia progression. Meta-analysis suggests only 1.7% per annum risk of progression to cancer, and therefore it still does need attention, and it is preferred to ablate rather than to surveil. There were certain post-procedural metrics that were decided on. Among patients who received CEIM, the recommendations for endoscopic surveillance is documented. So you wanted 90%. I'll come to the explanation of this a little further on the next slide. The threshold is 90%. During endoscopic surveillance after endoscopic ablation, biopsies of any visible mucosa abnormalities are performed, and this must be done in 95% of cases. Anti-reflux regimen is recommended after EET, and PPIs should be continued post-excision. pH must be controlled to get rid of it and to keep it under control. Furthermore, adverse events must be tracked and documented. This slide flow chart just shows that there is still a place for surgical fundoplication in Barrett's. However, this is only after extensive investigation and other forms of treatment. With targeted biopsies, non-narrowband imaging supported mucosal assessment significantly improves the detection rate for dysplastic and early neoplastic Barrett's mucosa, and it should be used in addition to 4-quadrant biopsies. In comparison with white light endoscopy, the narrowband imaging mode allows much better differentiation, particularly of flat discrete mucosal changes and their extent within an otherwise homogeneous area of intestinal metaplasia. According to this Bing classification, there are changes that occur in the mucosal surface pattern and the mucosal vascular architecture during the development of dysplasia and early neoplasia. In contrast to non-dysplastic Barrets Oesophagus, this validated classification can be used for histopathological prediction of the presence of possible high-grade dysplasia or early carcinoma within these often flat, poorly detectable areas. With regard to management of Barrett's, multimodal therapy for early Barrett's neoplasia, that's endoscopic resection of all visible neoplasias, followed by ablative treatment for residual non-dysplastic Barrett's mucosa, has become established as the standard therapy and is set out in national and international guidelines. These dysplastic lesions continue to be difficult to detect. Discrete dysplastic mucosal changes are often very small and flat, that's Barrett's 2B, and irregular in appearance, so that they are frequently not recognized. In addition, the monitoring protocols that have been recommended to date with 4-quadrant biopsies, for example, using the Seattle protocol and high-resolution white light endoscopy, covers only 4 to 5% of the total surface of the Barrett's mucosa. Most of the Barrett's epithelium is therefore not examined, so this is critical in our understanding of why narrowband imaging is far better than the Seattle biopsy protocol. The slide that I said I'd come to, CEIM refers to complete excision of 70% of intramucosal lesions within 18 months, and CE-N refers to complete excision of 80% of neoplasia within 18 months. So these are the intra-procedural metrics that must be adhered to. Among patients undergoing EET, a defined interval for subsequent EET is documented. Secondly, the rate at which CEN is achieved by 18 months in Barrett's-related neoplasia patients. And thirdly, the rate at which CEIM is achieved by 18 months in Barrett's-related neoplasia patients. Conclusions are the current screening strategy for Barrett's esophagus has not shown clear benefit. While the optimal method and timing of screening for Barrett's are uncertain, future approaches may benefit from using the low-cost initial method, which is the CDX brush, and screening a broader population. Greater attention needs to be paid to training regarding proper endoscopic inspection of Barrett's esophagus and documentation of findings. Endoscopic ablation or resection should be discussed as a treatment option for all patients with confirmed dysplasia. Recent quality metrics have been developed regarding the performance of endoscopic eradication therapy. This algorithm, which was actually published in 2010, still holds today. And the major problem is that risk stratification with biomarker and clinic risk panel is currently not available. So we do have to battle on and continue our best to surveil these patients. And currently the only real method we have currently is endoscopic surveillance together with brush biopsy as well as endoscopic biopsy. This slide, I'm going to show you a video to visualize a normal Z line.
To begin with, the area of the Z-line is rinsed free, and the Z-line is then visualized. Esophageal motility repeatedly obstructs viewing. The Z-line is visualized without enhancement and with eye scan. Spasticity in the distal esophagus is obstructing good visualization of the Z-line here. Air is therefore suctioned out of the stomach, so that a better view of the Z-line is obtained during withdrawal. 1% acetic acid is used to demonstrate the surface structure. An attempt is made to visualize the surface structure of the Z-line despite motility. Using a distancing cap, the mucosa is spread apart to allow better visualization of the mucosal details in individual areas along the circumference. The whitish acetic acid staining makes the surface structure more visible, and a short tongue of Barrett's appears on the left. Macroscopically, the rest of the Z-line has a gastric mucosa on it. Complete examination of the Z-line includes visualizing it in the inverted position. The Z-line is relatively low here.
Video is complete. So just to run through what you saw, there was initial visualization of the Z line, It's rinsed free and just with wash, saline or sterile water, and esophageal motility repeatedly obstructs the viewing. Subsequently, there's visualization of the Z-line without enhancement and then with eye scan, and then you saw the two images side by side. Z-line was visualized, spasticity in the distal esophagus is obstructing good visualization of the Z-line here. Air is therefore suctioned out of the stomach so that a better view of the Z-line is obtained during withdrawal. Then they wash the entire OG junction with 1% acetic acid, and this enhances the surface structure. An attempt is made to visualize the surface structure of the Z-line despite motility. Then they use a distancing cap, which is a little transparent clear plastic cap which is put on the edge, on the tip of the endoscope, and this allows the mucosa to be spread apart to allow better visualization of the mucosal details in individual areas along the circumference. The whitish acetic acid staining makes the surface structure more visible, and a short tongue of Barrett's appears on the left. Macroscopically, the rest of the Z-line has gastric mucosa on it. And then there's the examination in inversion with the scope retroflexed. The Z-line is relatively low here. Okay, so I've got one more video to show you. This is a excision of a small carcinoma in Barrets Oesophagus, followed by RFA ablation of non-dysplastic Barrett's.
Der 46-jährige Patient leidet unter einem Barrets Oesophagus C2M3.
Presentation of a 46-year-old patient with short segment Barrett's esophagus that had been receiving monitoring since 2009. A mucosal adenocarcinoma had been identified inside a small island.
Niedriggradige intraepitheliale Neoplasien gezeigt. Professor Rösch und Professor Fujishiro werden nun eine Endomikroskopie vornehmen, sowie eine EMR des Adenokarzinoms und gegebenenfalls eine Radiofrequenzablationstherapie.
Das ist ein Barrett natürlich, keine Frage.
Endoscopic imaging of the short tongue-shaped segment of Barrett's esophagus. Correlation with the previous findings before proton pump inhibitor treatment is shown. Above a small island of squamous epithelium at the 3 o'clock position, there's a tiny area above the esophagastric mucosal junction from which the biopsy was taken.
Und jetzt kommt eben der Kracher. Es gibt ein Bild vom Januar. Oberhalb von diesem weißen Punkt ist eine ziemlich aufgeworfene Erosion und ein Refluxstreifen. Hier ist diese Orientierungsinsel. Das ist ein Refluxstreifen wahrscheinlich, und wahrscheinlich hat sich dieses bioptisch gesicherte Geschehen hier abgespielt. Und daraus gibt es die Histologie einer hochgradigen Dysplasie bzw. Übergang in Adenokarzinom. Das war im Januar, seitdem gab es natürlich PPIs.
This area is imaged in detail, both in its unenhanced state and with Fujinon intelligent chromoendoscopy technology. The findings are also shown with magnification.
Da kann man jetzt natürlich auch über Pipette rumphilosophieren. Aber ich glaube, die meisten von uns hätten das halt als versprengte Barrettschleimhaut durchgehen lassen, und ich bin mir immer noch nicht sicher, aber aus dieser Gegend, und das kann man wirklich sehr gut nachvollziehen, im Vergleich mit dem alten Bild, weil es eben da diese Markierung gibt von dieser weißen Plattenepithelinsel. Das heißt, wie gestern, wir werden ja die Histo sehen, ob das wirklich stimmt, ist die Message, dass man sich auch so kleine Inselchen oberhalb des eigentlichen Barrett mal so ein bisschen genauer anschaut oder halt mal die Biopsiezange extra zückt. Dr. Fujishiro,
yes.
You don't like this island, huh?
Yeah, I don't like. This looks like this plastic change building under the squamous epithelium.
Wir haben das schon
Excision of the area around the small histologically positive mucosal island using the duet system. The area is suctioned in, the rubber band ligature is fixed, and a loop is then introduced through the working channel and pulled tight below the rubber band ligature.
So, das sitzt jetzt schön da drauf.
Wunderbar.
Mal auf. Drehen uns, legen es an und versuchen mal zuzumachen. Jetzt kommt der Strom mit Endocut. Den Blick hätte ich es gern. So. Das ist ja eine Technik, wo nicht unterspritzt wird. So.
The lesion is removed.
Wunderbar.
Da ist der Ring. Und ich glaube auch die Größe ist ganz okay.
Sehr schön.
Dann ist hier die Abtragungsstelle. Wir wollten eigentlich prophylaktische Koagulation zeigen, haben unterspritzt, dann hat es aber zu bluten angefangen. Hier sind 2 Gefäßstümpflein.
The excision surface, with a few coagulated vessel stumps.
Das war so, dass wir die Mucosa runterziehen und da drüber klippen. Dieses Specimen
Demonstration of the mounted resection specimen. The histological examination showed that the lesion was a mucosal adenocarcinoma that extended almost as far as the resection margin laterally.
Aber jetzt zurück zur Radiofrequenz. Also hier ist ja noch restlicher Barrett. Und
After inspection of the excision site, the residual short Barrett segment is ablated using a radiofrequency treatment. The whole range of accessories is shown first, from circumferential balloon ablation to focal devices.
Das werden wir auch jetzt nehmen, weil das gut steuerbar ist und gut abgrenzbar. Hier dieses Device, das wird auf den Arbeitskanal drauf gesteckt, hier diese Einführhilfe, und dann wird dieses Teilchen eingeführt, zusammengedrückt, eingeführt. Hier ist die blinde Seite, hier ist die Ablationsseite. Hier kommt es raus und springt auf. Flops.
Shown here is a focal device, TTS, that is introduced through the endoscope's working channel and is then used to remove the residual Barrett's piece metal.
Schön neben der Resektionsfläche. Dort zur Oesophagus-Motilität ziehen wir es mal rein, dass wir besichtigen, was wir da machen. Jawohl. Ich finde, dass die Sicht einfach besser ist als bei den anderen Focal Devices. Gerade wenn es um Millimeter geht.
Yes, end of that video clip. Very interesting to see how it is performed. And that brings us to the end of this lecture, online lecture. These are the references. You can take a look at these if you want further information. If there's any questions, please WhatsApp them to me directly. It's a bit of a short session tonight. Thank you very much for watching. Good night.